continue with chronic kidney disease, so since it follows the content, okay, and then we'll cover the rest. So what is chronic kidney disease? So basically, chronic kidney disease is qualified when the patient is start to lose glomerular filtration rate, but this glomerular filtration rate loss has to be present for at least 3 months consecutively, all right? You will see the classification in a second. In addition to that, chronic kidney disease, as we explained in the prior class, there is glomerular damage when you start losing macromolecules, including proteins, right? So when you start having more than 30 milligrams per day of loss of protein in the urine, so having proteinuria, that is also qualified as chronic kidney disease. Of course, depending on the classification that we're going to cover in a second. Okay, so you need to have at least loss of glomerular filtration rate, which the normal is 90 to 60. So having less than 60 in consecutive 3 months already puts you in the classification of chronic kidney disease. Okay, you know that one of the major risk factors for chronic kidney disease is actually having a resuscitated patient with either pre-renal, intrarenal, or post-renal renal failure that already has produced damage to the glomerular filtration rate, okay, or to the glomeruli. Cells that are present in the glomeruli, which are the mesangial cells and the podocytes that participate in the concentration of urine and the wasting of the byproducts of the metabolism of the kidney. Risk factors, well, diabetes and hypertension are the leading causes for that. But in addition to that, today we're going to be talking about glomerulonephritis. That is also part of the major picture for that. But as you could see, risk factors that precipitate acute kidney injury, when they're not caught on time and treated appropriately, those are also risk factors for chronic kidney disease. So I'm going to talk a little bit about each of them. What is glomerulopathies or glomerulonephritis? Basically, this is no more than a combination of inflammatory disorders that will attack the glomeruli. And essentially, the cells that are present in the glomeruli, which is, again, the podocytes, the mesangial cells, which participate in concentration of urine and filtration of the wasting byproducts of the kidney metabolism, okay? So there are many precipitating factors that we're gonna go one by one. For example, let me give you a big picture again. Glomerulonephritis is no more than an inflammatory process of the glomeruli, okay? That we're gonna go, for example, one by one, telling you what are these etiological factors that can produce glomerulonephritis. Remember that the major triad for patients that have glomerulonephritis is number one, since the glomerular filtration rate is affected, patients will have renal failure, right? And the consequences of renal failure that include volume overload and hypertension. We talked about that as one of the triads. Because the patients have damage of the glomeruli, patients will start losing macromolecules, which is protein. So patients will have proteinuria. So far, hypertension, proteinuria, and another cell that is also not supposed to be present in the urine, which is also present when there's damage to the glomeruli, is red blood cells, right? And this is called hematuria. Due to the proteinuria, which in this case the most common protein that is lost is albumin, patients of course have decreased oncotic pressure and therefore edema and volume overload. And giving a vicious cycle of volume overload that also precipitates more hypertension, right? In addition to that, we also talked that the majority of the glomerulonephritis, part of the classification is having hyperlipidemia and hyperlipiduria, even more when the patients have nephrotic syndrome, when they start losing more than 3 grams of protein in the urine, because the metabolism of lipids is moved or activated to produce or to nourish the cell, in this case the kidney cells. And the patients will start having hyperlipidemia and drops of lipids in the urine, which is lipiduria, and therefore Having hyperlipidemia is the major risk factor for atherosclerosis, which provokes a vicious cycle of hypertension and, of course, worsening of the condition. So that is glomerulonephritis. What can produce glomerulonephritis? Many diseases can produce glomerulonephritis. Number one, infectious causes, which are related to, for example, group A, beta strep, pharyngitis, so patients that do have acute bacterial pharyngitis, not only can have affected the glomeruli, and they have, they start having proteinuria, hematuria, hypertension, and edema. But in addition to that, other causes that we're going to go one by one. Besides the major concept that we have already discussed, glomerulonephritis is classified as three major, okay? Proliferative, sclerosing or scleromesangial. Basically, I'm going to explain that a little bit in a second, and necrotic. Okay? So what does it mean proliferative? Well, at the beginning, when the glomeruli starts producing a damage due to any type of inflammatory process, that we're going to go again as an example of etiology one by one, what happens is that as a compensatory mechanism, these cells of the non-damaged kidney, because you have two kidneys, will hyperproliferate, trying to compensate. That's basically more benign as a process, has more chances for recovery, and the prognosis, of course, and morbidity and mortality is less on the patients that have proliferative glomerulonephritis. Another major classification is sclerosing, meaning that sclerosis. So that means that the damage already has been so sustained or chronic that has produced scarring tissue. When the scarring tissue or the following classification, which is necrotic, is present, is irreversible. Okay? So those are the major three classifications. Now, disease-wise, now we're going to go, so proliferative, sclerosing, and necrotic.
So that one is sclerosing irreversible?
Both. Like when you have a scar tissue, the functionality, even if it's in the skin, is lost. Okay? So disease-wise, now I'm going to go one by one to give you an idea. It's not that you're going to be a nephrologist after this, but to give you an idea how certain disease process can produce glomerulonephritis. Okay? For example, we have focal segmental sclerosis, which is no more, for example, patients that have HIV. Any autoimmune condition can produce damage to any vessel, and that includes the renal arteries, and therefore the glomeruli, okay, and produce glomerulonephritis. Another example, patients that are on heroin abuse, that can induce an inflammatory process and produce glomerulonephritis. So the most common two, and I will give you another one, the most common two disease processes that can produce focal glomerulonephritis or nephrosclerosis, and as you can imagine, having sclerosis is irreversible, are patients, for example, that have heroin abuse or patients that have HIV. Okay? Another example of, you don't need to know this.
Okay.
Just open your mind. No. That's too much. No. I'm just giving you an idea. You need to know, you're practitioners, right? So when they tell you, oh, this patient has IgA nephropathy, you need to know what are they talking about. Okay? So at least so far, you need to know that, for example, patients that have any type of infectious disease, including Staphylococcus aureus, can induce glomerulonephritis. Patients with any viral condition, virus, influenza, they can induce any autoimmune condition and therefore produce glomerulonephritis. Okay? A condition that can produce focal glomerulosclerosis is called Alport syndrome. This Alport syndrome is a genetic disease. You're actually born with it. okay? That basically they have, you're born with a deficit of collagen 4, which is a factor necessary or a product necessary for these mesangial cells, the podocytes, for the kidney to produce their normal functional filtration, okay? Alport syndrome as well, the same as other, for example, Wegener granulomatosis, you would see in a second. Those patients could have a microangiopathy. What that means is that either a viral condition, either a genetic disease, either a bacterial infection, either lupus, either rheumatoid arthritis, any disease process can activate the immune system. And since the patients will start producing autoantibodies against a particular tissue in the body, in this case, the kidneys, but you would see that in Wegener's granulomatosis, not only the kidneys are affected, the skin is affected, the upper respiratory tract is affected, the lungs are affected, the synovium is affected. So basically, as a whole group, what I want you to know is that either if it's focal or idiopathic crescentic or membranoproliferative, it doesn't matter. These are diseases that the patients do have either because they were born with it, okay, as a genetic predisposition against the collagen 4, which is necessary for the basement membrane of the kidney to produce filtration, or because you have been exposed to a virus, bacterial infection, or you have an autoimmune condition such as lupus, rheumatoid arthritis, Sjögren's, scleroderma, that produces what's called hypersensitivity reaction type 3, if you recall that, is no more than the production of autoantibodies against a particular tissue. And that tissue could be any tissue in your body, including your eyes, and you will understand this better when I will discuss autoimmune conditions. But another tissue that could be selected is the basement membrane of the glomeruli, the kidney, okay? And therefore producing proteinuria, hematuria, hypertension, and edema, which are the base symptoms of any type of glomerulonephritis, and of course more exacerbated in metabolic syndrome. Do you understand so far? Okay. So, as I told you, for example, in focal glomerulosclerosis, patients, HIV patients that have heroin abuse are more exposed. Genetic conditions such as Alport syndrome are more exposed to that. For example, in patients with IgA nephropathy, which is one of the most common autoimmune conditions that could produce glomerulonephritis in this country. Basically, these patients, what they do have is no more than a vasculitis against the kidney when the patients are exposed to any type of MRSA, methicillin-resistant Staphylococcus aureus, okay? So now, for example, you have cellulitis, and you develop MRSA that can travel into your bloodstream and produce a bacteremia, and the complications of that bacteremia by MRSA could be glomerulonephritis. You understand? Yeah. Okay, good. In addition, for example, if you have a patient with Wegener's granulomatosis or hemolytic uremic syndrome, hemolytic uremic syndrome patients, most of the time, is the food poisoning. It was actually discovered for the first time by eating hamburgers, uncooked meats. Oh. And due to staphylococci or streptococci, the patient develops an autoimmune hypersensitivity reaction type 3, and basically autoantibodies are created against the glomeruli, and the patients produce glomerulonephritis. Amyloidosis as well is an autoimmune condition that there's no more than base membrane of the glomeruli, autoantibodies are created, and again, attack the tissue. And you could determine that by either doing a biopsy of the nodules that are present in amyloidosis, or by your analysis, and you are able to see the autoimmune, the auto antibodies present. Any question? Okay. Besides that, diabetes, for example, is this a risk factor? Polycystic kidney disease, we're going to be talking about BPH and renal artery stenosis in a second. Okay? So borderline is that either a patient having an acute kidney injury that is not caught on time and treated appropriately leads to chronic kidney disease, or the patient, for example, in renal artery stenosis, that the patient is asymptomatic and is only diagnosed when the patient starts having hypertension and already renal damage. That could be one example of chronic kidney disease. Remember that our goal is that acute kidney injuries will be reversible by trying to identify the underlying conditions. Once the patient has chronic kidney disease, even though you can treat the underlying conditions such as lupus, etc., the damage has been produced already, and therefore that particular damage is irreversible, but of course you could at least stop progression, okay? So let me explain this. Normally, as I explained last week, when the patient has acute kidney injury or acute renal failure, either by hypovolemia, which is the most common pre-renal one, or any cardiovascular condition, or intrarenal by nephrotoxins, or either by obstruction by a renal calculi. Once you identify the condition and remove, it's reversible. But at the same time, we went over explaining the autoregulatory responses. Whenever the patient is in acute kidney failure due to any of the major classifications with renal, intrarenal, or postrenal, I explained the renin-angiotensin aldosterone system, right? So that is one portion, how the kidney tries to autoregulate to improve renal filtration and, of course, glomerular filtration rate. Another form of autoregulation for the kidney is when one kidney is damaged, the other kidney tries to take over and produces what's called hyperfiltration. It's no more than the amount of glomeruli or mesangial cells hyperproliferate to be able to overcome the function of the other kidney that is damaged. Of course, this is a temporary condition, okay? Until, of course, you don't catch up with time and treat it appropriately, therefore the kidney will fail. Okay, so I want you to remember this portion for renal artery stenosis as well, okay? But of course, once the other kidney fails, the predisposition for both moving into sclerosis or process is detrimental, okay? So let me explain you two concepts that you need to understand, and yes, this will be tested. And I don't want to keep saying test and test and test because I'm a pre-recorder and this could go to other sections. What is azotemia and what is uremia? They're not the same, okay? Azotemia is no more than an elevation of BUN and creatinine. That the patient could be completely asymptomatic. Do you understand? That's the key. Asymptomatic patient with an elevated BUN and creatinine. And when I say asymptomatic, I'm not referring to oliguria or anuria, because even though it is a sign, it's not a symptom provoked by it. Uremia, on the contrary, is no more than the clinical signs and symptoms that the patients have associated with elevation of urea. Let me give you some examples, even though it is in your PowerPoint. If I now accumulate urea, that could affect the brain by giving you encephalopathy. So having encephalopathy, having any changes in mental status confusion, up to the point of seizures is uremia. If we go to the continue the peripheral nervous system, patients tend to have involuntary movements or tremors produced by accumulation of uremia, and that is called asterixis. That is a sign of uremia. Another sign of uremia by peripheral neuropathies is an involuntary movement of the legs, which is called restless leg syndrome. Of course, restless leg syndrome has many causes, but having elevation of BUN and creatinine and having restless leg syndrome, which the patient never had before, is a sign of uremia. Uremic frost in the skin, having a skin rash associated with uremia, meaning elevation of BUN and creatinine, is a sign of uremia. Having accumulation of urea producing inflammatory processes in the body, such as pericarditis and pleuritis, and you know what the symptoms are, right? The chest pain, which is sharp, worse with inspiration and cough, and the pericarditis that is worse when you lean back and is better when you lean forward, and you have a widespread systemic elevation of the EKG, that is a sign of uremia. Do you understand? So just by having an isolated BUN and creatinine elevated, and the patient is completely asymptomatic, meaning complications of the accumulation of uremia, is not uremia, it's azotemia. Did I answer your question? And I'll go and present you more examples of that, okay? Now, most of the time when the patients have a BUN and creatinine of 30, 40, it's not going to give you signs of uremia, right? Or damaging off to produce it. Most of the time is when the BUN is 60, 70, 80, 90, 80, 100, okay? Now, this is, again, we talked about this last week, but let's refresh it again. If you concentrate on the functions of the kidney, since the patient has chronic kidney disease, again, loss of GFR less than 60 for 3 consecutive months, patients will start accumulating nitrogen waste byproducts, which the main will be urea, okay? And therefore, since the kidney is in charge of volume control, sodium control, and blood pressure control, the patients would have increased sodium water retention and signs and symptoms of volume overload, which it could be pulmonary edema, lower extremity edema, and anasarca, right? But in addition to that, the patients could have dilutional hyponatremia, and the patients tend to have hypertension as well. You know that the function of the kidney as well, because of aldosterone being present at the level of the distal tubule, they cannot excrete properly potassium, therefore they accumulate potassium, and the patients with CKD tend to have hyperkalemia. And all the manifestations of it, which could include deep tendon reflexes decreased, muscle weakness, and also, remember, in hyperkalemia, you have high peak T waves in the EKG, okay? Now, in addition to that, hormones are affected. You would see how the function of parathyroid hormone is affected, giving the patient hypocalcemia and hyperphosphatemia. In addition, sex steroids are affected. Patients with CKD tend to have decreased libido, impotency, these are the males, and maybe elderly patients, you wouldn't care, but patients could be young and have chronic kidney disease as well, okay? And for us, an ovulatory cycle, so can become pregnant and also decrease libido. In addition to that, you know, hormones, erythropoietin, that is not secreted appropriately, so therefore the patients have normocytic chronic anemias. They tend to have hypothermia. They can't regulate properly the temperature. So these patients, and on top of that, due to the volume overload, they most of the time become hypothermic. We talked about how the patients become hyperlipidemic. The more protein they excrete in the urine, the more the lipid metabolism is smooth, then they tend to have hyperlipidemia and hyperlipiduria. You need to know the classification of chronic kidney disease.
For the imbalances of sodium and water and potassium, do you care if it's an early stage or late stage or anything like that?
I have seen end-stage renal disease patients that don't have any problems with potassium at all. And I have seen early stages that they become hyperkalemic. So the guideline says that even though you expect these changes to be more prominent when the patients are in stage 3 or more, the GFR or the elevation or the level of urine creatinine does not accurately correlate with the signs and symptoms of uremia or the complications based on electrolyte imbalance that the patients might have. So the normal GFR, glomerular filtration rate, is more than 90%, right? So when you are here, you're completely normal. Unless you have a normal GFR and you start depleting proteins. Sometimes the patients are in that classification and it's classified as mild, okay? Then you have stage 2, which if you're smart is more than 90, right? 60 to 89. Then it's supposed to be 50 to 60 and therefore, right? So stage 2, basically 60 to 80. And this is, in the classification, is mild to moderate. Here is moderate to severe. Here is severe. And here is end-stage renal disease. The reason why it's combined is because there's 2 types of classification. Classification based on GFR, which are basically 3 stages, but it's 3A, 3B, depending on your book, okay, and the end-stage renal disease. And another classification is based on the amount of proteins that are present in the urine, which the mild to moderate is more than 30 milligrams per deciliter. Remember, less than 3 grams per liter, it's the same thing, right? Over day. And moderate to severe is more than 300 milligrams per deciliter per day. So when you have less than 3 grams, you're mild to moderate. When you're more than 3 grams, you're severe, in other words.
The patient can be in stage 5 and not being on diet.
No.
That's another part. Treatment-wise, these patients up to stage 3, you could treat them medically, conservative management, okay? When they are already on stage 4 and 5, depending on the classification that you see, because remember I told you, 1, 2, 3A, 3B, and then 4, and here is 1, 2, 3, 4, 5. It doesn't really matter. Mild to moderate, the patient's conservative management with treatment, and severe to end-stage renal disease, you have to think to put the patient, even if the patient is not on stage 5 yet, which is end-stage renal disease, you have to start thinking about if you're planning a fistula, to put the fistula and start maturing the fistula, because it doesn't take from one day to another, right? If you see that the renal function progressively deteriorate and you're already on stage 4, start planning with the AV fistula. The patient comes to you for the first time in stage 5, of course, straight to dialysis with a central venous catheter.
How long does it take for the fistula to work?
A month.
Matter? A month?
Some patients more, because you need to have a root present. Okay? So again, what are the major complications? Well, the patients tend to have hyponatremia, most likely dilutional hypernatremia due to the volume overload, hyperkalemia, metabolic acidosis. I basically explained to you the reasons why the patients have metabolic acidosis. First, bicarbonate is secreted at the level of the proximal tubule when the patients have renal damage. They can secrete bicarbonate, so therefore, when I say secrete in kidney means excretion, okay? So they tend to retain hydrogen ions and therefore metabolic acidosis, and they do have high anion gal metabolic acidosis. Patients also get metabolic acidosis due to hyperkalemia, okay? So those are the major two factors, and of course, accumulation of urea. Mineral bone metabolism, remember that I explained that the parathyroid hormone basically is activated in the presence of course, calcium and phosphorus level. So the patients with renal failure, since the PTH, basically the major function of the PTH, if you remember in pathophysiology, PTH is activated whenever it's perceiving low calcium level in blood. So if you have hypocalcemia, PTH gets activated and allows reabsorption of calcium at the level of the intestine, at the level of the bone, and at the level of the kidney. Since the kidney is damaged, one of the organs that participate in the calcium metabolism with the parathyroid gland is affected, so the calcium cannot be reabsorbed at the level of the kidney and therefore excreted. So more hypocalcemia develops, and therefore, since the opposite effect is the phosphate level increases, okay? But the body is very smart and tries to get calcium from another source, in this case the intestine, producing malabsorptions, and also from the bone, extracting calcium from the bone. Patients with renal failure, even if they're not elderly, they tend to have osteoporosis and pathological fractures due to the extraction of calcium from the bone. Cardiovascular and pulmonary disorders, well, what happens when you have accumulation of urea? It's irritant for any tissue, so produces an inflammatory process. So the patients with CKD, they tend to have highly common, which is a question for board examination, uremia causes pericarditis, okay? In addition to that, they can cause, due to the volume overload and the constant and uncontrolled hypertension, patients tend to have cardiomyopathy, most commonly dilated cardiomyopathy. And that's another contributing factor for pulmonary edema, okay? Pulmonary disorders, well, if the kidney is unable to perfuse properly, that produces less hemoglobin, therefore less oxygen carrying capacity, and the lung tends to shunt, meaning that at the beginning tries to overcome and have it produced, and the patient is constant in respiratory acidosis because they become tachypneic. And once the patient becomes more volume overload and they have pulmonary edema, that's another contributing factor for shortness of breath, right? So one portion, the patient is short of breath and dyspneic because of the amount of hemoglobin, so the carrying oxygen capacity is decreased. Second of all, they have pulmonary complications due to the volume overload of the renal failure, contributing to pulmonary edema and pleural effusions. And another factor is, as it produces pericarditis, can also produce pleuritis and pleural effusions, okay? Hematological abnormalities, we talked about the main hematological abnormality would be the non-secretion of erythropoietin and therefore normocytic normochromic anemia. Neuromuscular abnormalities, as I said, one is due to the potassium producing weakness and deep tendon reflexes that are affected. In addition to that, patients can have hysterexia, patients can have restless leg syndrome, and up to the point that uremia can produce seizures, okay, myoclonus. Gastrointestinal abnormalities, one of the portion is that trying to extract calcium from the intestine produces a lot of malabsorption syndrome and diarrhea, and therefore vitamins are not absorbed properly. In addition to that, of course, the transient tract is accelerated, therefore the patients tend to have diarrhea and more dehydration, more electrolyte abnormalities. Endocrine abnormalities, we have one by one there. They tend to have insulin resistance and therefore hyperglycemia and diabetes. So even if diabetes was not the precipitating factor for renal disease in this patient, it would happen eventually, type 2 diabetes. And one of the dermatological abnormalities that they tend to have is urinary frost and therefore rashes and a lot of pruritus. And here you have them one by one. So by sodium and water accumulation, makes sense that if you retain sodium and water, you will be more overload. So the patients would have pulmonary edema and all the signs and symptoms of CSF, most commonly dilated cardiomyopathy, so therefore they tend to decrease ejection fraction and have more left-sided valvulopathy and left-sided problems than right. And of course, because left fails, right fails, so eventually they tend to have right-sided heart failure and therefore ED and edema across the body, including ascites. We talked about diarrhea and having vomiting. We talked about how most commonly the temperature regulation is affected and they have hypothermia, but of course, having renal diseases and depleting the adaptive immune system, they can't fight infections properly, so they tend to have a lot of infectious process superimposed, and that's when they have fever. But most of the time, they do have hypothermia. Another sign for fever will be the dehydration state. For example, when you put them on hemodialysis or when you take out a lot of fluid with diuretics. When you dehydrate a patient, the patients tend to have low-grade fever. Otherwise, volume overload would give you hypothermia, okay? Now, how do we treat these patients? Well, the patients, first of all, if they're in mild, moderate stages, what you have to do is treat the underlying condition and also treat the symptoms. It's expected that we're going to go one by one, but it's expected that if you have volume overload state, the first leading treatment that you will give is diuretics, right? Which diuretics work the best? Unfortunately, if you have a GFR less than 20, listen to this, thiazide diuretics don't work at all, so don't even think about thiazide diuretics unless you have mild to moderate CKD. The best diuretics that work here are Lasix and Bumix, okay? And also convolutures.
High dosage, no?
Yes.
Very high dosage.
Now, if it's mild to moderate, the dose is not affected, but if you already have moderate to severe disease, it has to be 60 or more. Or 2 milligrams of Bumix for it to work.
I had this patient over the weekend, he's peritoneal dialysis, like my first peritoneal dialysis, so he was off dialysis for like over 3 months, and then it started getting worse again. Then he started dialyzing, but then they were giving him Lasix at like 80 twice a day.
And if you have to combine, try to combine a loop diuretic with a convolute diuretic. Ethacrinic acid or aldactone works really well with them, but be careful with aldactone because aldactone is an aldosterone antagonist and increases potassium.
So how you should recommend Lasix on Bumix?
If it's mild to moderate, Lasix works really well. But if it's moderate to severe, if you're going to use Lasix, 60 milligrams or more, the Bumix is the best for them.
You use words for both for that, just
But you see it interchangeably. Now, once you have severe to advanced disease, which is stage 5, and end-stage renal disease with a GFR less than 15, nothing works. Nothing. Even if you still urinate, diuretics don't work. Hemodialysis, okay? Or, of course, peritoneal dialysis. Now, let's treat hyperkalemia. Forget about when does it occur and all that. Let's treat it. First of all, you know that, again, since the distal tubule and convolute tubule is not working properly, be very careful. That doesn't mean that you're not going to be using potassium-sparing diuretics, but if the patient is already on potassium-sparing diuretic and the patient has hyperkalemia, the first rational thing to do is discontinue it. If the patient is in CKD and the patient has hyperkalemia and is treated with ACE inhibitors or ARB, you have to stop them, right? Now let me rephrase something that I said last week so you don't be confused. When the patients are in acute renal failure, the reason why you stop ACE inhibitors or ARB is because if they are on board, the patient cannot auto-regulate. You understand? So it's due to an auto-regulation, to allow auto-regulation, which is the normal physiological response for the kidney, right? To perfuse the nephron. Once the patient is in chronic kidney disease, it's actually a benefit for the patient. Autoregulation is already lost. When you fall into chronic kidney disease, you have lost autoregulation completely. So there is no, unless you, of course, you're going to pre-renal on top of CKD, because any patient with CKD can be dehydrated, right? So unless you have evidence of an acute renal failure on top of CKD, you do not need to discontinue ACE inhibitors or ARB on patients that have CKD, because it's been proven that ACE inhibitors or ARB will decrease proteinuria, therefore will stop the progression of the disease. Besides the fact that one of the complications for CKD is left ventricular heart failure, it actually prevents remodeling from coming. So it's a benefit for CKD patients. Now, when do you stop it? Well, you stop it either if the CKD has a pre-renal acute exacerbation, or if you have a patient with hyperkalemia, because ACE inhibitors will not allow the normal function of aldosterone of excreting potassium, patient will retain potassium and therefore they will have hyperkalemia.
So how can you have an acute on chronic?
You can. Like if you move from the baseline, you are already in acute exacerbation.
Yeah, but if you're already on chronic disease, how are you have an acute?
Because it could be baseline.
All right, you have, for example, a patient that is already, let's put the extreme,
It just depends what stage. You can be like chronic stage 2.
You have a
or
patient-
3.
It doesn't really matter, let's go to the extreme. You have a patient with end-stage renal disease on hemodialysis. Imagine that the patient with hemodialysis has a BUN of 103 and a creatinine of 11. Well, that's an indication for dialysis. That's to start, okay? But if you have a patient on hemodialysis and the BUN and creatinine before dialysis is 103 and 11, the purpose that you do dialysis is not only to remove volume, but also to remove the urea, right? So you expect that the next day, this BUN, for example, will be 80, and the creatinine, let's just put numbers, is 9. If on the contrary is worse, now what happened is that you remove so much fluid that the patient is under a renal state. Besides the fact that, of course, the patient is going to be hypotensive, you're going to see signs and symptoms of volume depletion. But you could also monitor it by BUN and creatinine. Patients with end-stage, the GFR is not going to change, because the GFR, if it's 10, it's 10, it's not going to change. But symptomatology, so clinical appearance of the patient, by having hypotension, for example, or tachycardia, or having a worsening of the BUN and creatinine the next day of dialysis, that's an indication of an acute.
That means you're over challenging the patient. Wait, why? So isn't that?
So you have to give fluid.
Yeah.
Very judiciously, because these patients can manage volume properly, but you still have to give them fluid.
If you do the analysis and the numbers are better, you're talking like.
Not only you are improving the wasting byproducts, so you are excreting urea properly, but also at the same time, the urea portion of the BUN is better.
So in that case, it will be like exacerbation of the CKD.
Correct, because you're putting the patient in volume depletion, which is pre-renal state, even if the patient is an end-stage renal disease patient. Okay, if you start vomiting, sometimes, let me tell you what happens in clinical practice. Sometimes we don't look at the numbers, we look at the history. You have a patient with end-stage renal disease, and the patient has been vomiting or having diarrhea, and now you have a baseline BUN and creatinine, and it's worse, and the patient had proper dialysis the day before, outpatient, that most likely is because the patient is really depleted. okay? But in addition to that, forget about the numbers. You have a patient on end-stage renal disease or CKD patient in prior stages, not end stage. And the patient is having diarrhea, vomiting. Or the patient had a hematemesis, major blood loss, and the patient's now hypotensive. It's like any other regular patient. You have to assume hypovolemia and treat as such. It doesn't matter if the patient is on dialysis. You understand?
Okay, so as far as the acute on chronic, so if you have an already established chronic kidney disease patient that has been followed by a nephrologist, and you can see that, you know, their creatinine is more or less a certain number, and they come in and all of a sudden their creatinine is much higher, is that acute on chronic?
Well,
Or
really
is that-
depends, really depend, because for example, if it's a medication that the patient is being on, that it could be, imagine that the patient had pneumonia, and you put the patient on Levaquin, okay? Or you put the patient on Rocephin, which is a nephrotoxin for the kidney, even though we do it all the time, okay? And the patient now has a worsening of creatinine. It's not that the patient has volume depletion and renal state, it's due to the nephrotoxic substance. You have to look at the history. Of course, it's an acute kidney injury on top of the CKD,
Right.
but in this case will be intrarenal due to the nephrotoxic substance being present before.
You would.
In that case, you don't have to
it
give
is
fluid to the
acute,
patient.
yeah.
In that case, you basically remove, or you have to assume that is produced by the antibiotic. And the only thing, unfortunately, that you have to do is just monitor edema and creatinine. There's nothing to do once the patient was exposed already to the medication. You can flush it out with volume in these patients because they can't manage volume problems.
But you could do that while you dialyze.
Yes. Now, if the patient is a candidate for dialysis, which we're gonna go through the indications of dialysis, then of course you can dialyze the patient and get rid of the toxin
Colado.
in blood. If the patient is not a candidate for dialysis, you're not gonna do dialysis for every single patient that has been on any type of nephrotoxin, understand? Any other question?
Wait, because I'm still a little confused
Tell me, confusion.
about when, like, if you, in the same numbers, like you dialyze, the numbers are better, we're assuming it was pre-renal.
If the numbers are better,
No, that's
No, no,
normal.
no, no.
That's
It's
normal.
the chronic that got better from the baseline.
okay. This patient has end-stage renal disease. You expect the numbers to be better after dialysis.
If they're worse, then it's pre-renal.
Now, if the creatinine is getting worse instead of better after dialysis, or the BUN jumps like 20% more, that means that 3 liters for that patient might be too much to take out. And then you have to give albumin, or you have to give some volume, minimal volume, not 30 mLs per kilo because they can't handle the volume properly. I would do like half.
Yeah.
If it's, if for this particular patient, 3 liters was the 30 mLs per kilo, I'm not gonna give a bolus of 3 liters, I'm gonna give maybe 1 liter, you know, to try to replace the volume that the patient lost. Most of the time you see it in clinical symptoms, the patient's, having hypotension, or the patient is very weak.
When they get
For example, we had a
headaches,
patient this weekend in the hospital, okay? This patient is awaiting cabbage. But the patient had a borderline mild to moderate CKD, and it was extremely necessary for him to go to cardiac cath. So of course, the iodine contrast provoked more damage to the kidney, right? And therefore, they're dialyzing the patient to be able to prepare him for cabbage. Now the patient, I remember I was with Bosch on Friday, and she called me and say, please, I'm not in the hospital anymore, can you please order an ABG? This patient is obtunded. It can't wake him up, but the patient's super obese, and the patient has history of obstructive sleep apnea. So she thought that it was CO2 retention. I told her the patient does not have CO2 retention. I specifically talked to the attending physician, and I told her, listen, they're drying him up so much that I can open the patient and open the break so you can see that the beginning of the BUN and creatinine before cardiac cath, this patient has BUN of 40, okay? And before cardiac cath, this patient had it like, let's imagine the number 2.5 of creatinine, okay? And dialysis was supposed to make him better. Well, first of all, they did a trial of fluid, patient didn't improve. So they did another trial of diuretics to see if the patient improved. And after that, they couldn't improve the BUN creatinine, so they started dialysis to see if they could prepare the patient for CABG. The BUN and creatinine, I will show you during the break, was going, I don't remember the number exactly, but they were going higher and higher. And I called the attending and I said, listen, I believe you're drawing this patient too much. The patient was awake and alert with me in the morning when I did the rounds. Then in the afternoon, the patient was obtunded, and that day, the patient needed dialysis, and I told the attending, call the nephrologist because I think they're drawing him too much. Sure enough, she calls me with the obtundation, and I said, no, don't do an ABG. I did an ABG in the morning, and it was perfect. And the patient was talking to me. That is uremia. Patient was encephalopathic due to uremia. And of course, sure enough, I mean, it's not that you're smart. If I go for pulmonary, that doesn't mean that you only see pulmonary. You have to see the whole picture, you know? And I did not intervene because you know how it is. There's so many hands on the plate. But at least I told the attending, and sure enough, the patient was so dry. Then they stopped dialysis, a lot of IV fluids, and the patient got better. Uremia.
Oh wait, I have a question.
So in that case, the patient was in severe CKD due to iodine contrast plus the baseline that the patient already had, worsened his condition and put him from mild to moderate to severe, requiring dialysis. But you're supposed to get better, number-wise, no worse. The patient was getting worse, that's because there's a lot of volume depletion. Stop it.
They saw his weight, they saw his swelling, and they wanted to challenge it instead of just.
The patient was obese but looked like a prune.
Exactly.
Besides the fact, when they call you and they tell you patient's obtunded not because of the CO2, don't even bother doing an ABG.
But if they are doing dialysis, were they not doing ultrafiltration? Because why did his uremia stay high if they were dialyzing him, even though he was really dry?
They tried
Why did the
everything
uremia stay high?
because he was getting,
Because he was
remember,
concentrated without the
his
body.
blood,
Dehydration.
blood.
It was too dry. Okay.
Claro, si no hay volumen, está concentrado.
Okay?
Yeah, that's.
So please, so again, look at the whole picture, clinical picture. Sometimes it's better than numbers. Again, going back to numbers, do you remember last week when I went over a table of content about the fracture excretion of sodium? When the patient is dehydrated, how the fracture excretion of sodium is less than 1? That's a normal patient. A normal patient that doesn't have CKD, that is already able or still able to conserve sodium when the patients are dehydrated. Listen to this. Once the patient has CKD, how is the ability of that kidney to conserve sodium? It's not present. So do you think that fraction excretion of sodium or a sodium spot in urine is accurate to measure 3 renal states, meaning hypovolemia in a CKD patient? No. You have to go by clinical symptoms the majority of the time. And the prior history. What happened before? Medicine most of the time is common sense. It's not like you're like super bright.
You'd be surprised.
No, of course. No, I'm not surprised. I'm not surprised. I'm not surprised. So in addition to that, you have to be very careful the diet that you give to your patients. We're going to go through the allowance. We're going to go through the allowance in a second. But it makes sense that if the patients, for example, having proteinuria, depleting large amount of protein, you give them large amount of protein in the diet, they're going to keep excreting and having more hyperlipidemia. So you have to stop the cycle. If the patients cannot control the reabsorption of sodium and they tend to retain sodium and therefore volume overload and hypertension, it makes sense that you limit the amount of water intake And you also limit the amount of sodium intake, right? The same as calcium, the same as phosphorus, etc. Yes?
I was just wondering, when you said that to the attending, don't bother with the ABG.
No, that was my attending, Bosch. No.
I know, but what did they?
When you have a good relationship with your physician, I told her, no, don't even do it.
But what was their response to that?
No, her response was, let me call the nephrologist. I told her, forget about the ABG. I did an ABG in the morning and I know it's not an ABG. On the contrary, the patient was tachypnic because there was a metabolic acidosis, because there was a renal failure and high uremia. And the reason why the patient is like that is because the patient is retaining urea. That's the reason why the patient is encephalopathic. Call the nephrologist. And she called the nephrologist. Okay? I can show you the text. But again, I mean, if you actually look at your patient and review everything, even if it's not your specialty of expertise, it's too close to. Okay? Now, diabetic patients, the reason why, first of all, induces renal failure, and also why renal failure can induce diabetes as well, as I told you. One is because there is insulin resistance. In addition to that, they tend to have low renin levels. So their response to autoregulation, remember, catecholamines, renin-angiotensin aldosterone system is also impaired. So that's one of the reasons why diabetes is one of the leading causes of CKD, because they cannot autoregulate properly due to the lack of renin, and therefore the entire autoregulatory cycle. Okay? Now, let's treat hyperkalemia. How do you treat hyperkalemia? Normally, let me tell you the choices. For hyperkalemia, okay? If you can use the GI route, use it. So that means that kayaksalate, for example, 30 milligrams, can do it. Inducing diarrhea, which is one of the routes to eliminate potassium, okay? Another way to treat potassium is to give insulin. So insulin brings the potassium inside the cell, right? So basically you give 10 units of insulin, IV, followed by dextrose, because if the patient is a normal glycemic patient, even if it's hyperglycemic, you can induce hypoglycemia. And therefore it has to be followed by an amp of D50, dextrose. Another way to treat, which is an adjuvant of treatment, not isolated treatment, it doesn't work by itself, is giving albuterol nebulizers. Because albuterol is a beta-2 agonist, so brings the potassium inside the cell as well, okay? So again, don't just give nebulizers every 3 minutes, which is a treatment, but it's not isolated. It's like in addition to, okay?
In addition to the first two, to like the insulin?
Yes,
or-
if you decide to do insulin with dextrose or kayaksalate by GI route, you could add Duonab or albuterol by itself as a nebulizer solution, 2.5 in a nebulizer solution every 3 minutes for at least 3 treatments, and that helps a lot, okay? Doesn't matter if the patient is bronchospastic or not, you're doing it due to the potassium level. It is an indication, it's in the guideline. Now, how do you think it started as an off-label use? Because every time you would put the patient on a nebulizer and then a beta-2 agonist, the patient will become hypokalemic, and basically they discover that every single beta-2 agonist will bring potassium inside the cell. And but it's an adjuvant, it's not primary treatment, okay? And of course, how can sodium bicarbonate decrease potassium level? Basically by an exchange of cations at the level of the cell. But again, be careful with the sodium bicarbonate, because
It can induce pulmonary edema by hypertonic, being a hypertonic solution. So brings a lot of water inside the cell and therefore produce pulmonary edema. I would only reserve sodium bicarbonate when the patient has a pH less than 7.2 of metabolic acidosis, even though I see it all the time. But that's clinical guidelines. I understand. But what you do in clinical practice, you have to erase from your brain, because otherwise you're going to be wrong on examination, because we test based on treatment guidelines, not practice. And of course, the most definitive treatment for hyperkalemia on patients that have end-stage renal disease is hemodialysis. That doesn't mean that you're going to wait for hemodialysis to happen. Listen to me. Listen to me. The gold standard treatment for hyperkalemia on an end-stage renal disease is hemodialysis. Okay? Now, this is an exam. In clinical practice, you will order the hemodialysis or order nephrology consultation if the patient is not on hemodialysis, or call nephrologist to start programming hemodialysis stat, okay? But meanwhile, you're not gonna wait, right? You're gonna order at least insulin and dextrose, right? With albuterol as an adjuvant. Or Kayakslate, of course. Be careful with the Kayakslate. You know, look at the scenario of the patient. The patient's dehydrated, you're not gonna provoke more diarrhea, right? So, use your brain. Metabolic acidosis, again, these patients tend to have a combination of, you would see that in 669, in acid-base imbalance, combination of non-anion gap versus high anion gap metabolic acidosis, depending if they are in acute kidney injury or chronic kidney disease. But borderline, you can treat the acidosis with sodium bicarbonate, again, when the pH is less than 7.2. Meanwhile, you program hemodialysis, because one of the indications of dialysis is metabolic acidosis in the end-stage renal disease, okay? And of course, try to look for the underlying condition that is provoking that. Okay, bone disease, as I told you, I explained already how PTH works and how calcium tends to be low on patients with chronic kidney disease, and in interchange they have hyperphosphatemia. To be able to correct this, you have to use vitamin D analogs, which are phosphate binders, phosphate binders. The most common is the calcitriol that you give to these patients, and there are more modern medications already in the market.
What about
No. That's basically for osteoporosis. It's a vitamin D analog, but works more for bone reconstruction, like for osteoblast and all that. But it doesn't bind the phosphate as much as the calcitriol. Okay? So again, how do we treat hypertension? Let's treat hypertension on a CKD patient. ACE inhibitors or ARB. If you remember the ANC8 guideline, 9 common or already in the market, patients with CKD and diabetes, regardless of their age, leading #1 treatment, first line, however you want to call it, ACE inhibitors or ARB, unless contraindicated. And they're only contraindicated when the patients have an anaphylactic shock, right? When the patients have hyperkalemia, which is a temporary condition, and then you resume. How else do they benefit? Remember, if they have mild to moderate disease, thiazide diuretics still work, even though chlorthalidone works better for them in the CKD patients, if you're using thiazide in the mild to moderate disease. Otherwise, calcium channel blockers or beta blockers of your choice will be the second line. let's treat pulmonary edema, we said already, right? So volume overload is only treated if you have mild to moderate diseases and the patient is not an end-stage renal disease that needs hemodialysis, because pulmonary edema is an indication for dialysis on an end-stage renal disease patient. Otherwise, loop diuretics work the best. Okay? We talked about how to treat hypertension. How do you treat pericarditis due to uremia?
Well, but the thing is, if you have CKD, you don't want to give an acute stage, you don't want to give end-stage because of the prostaglandin.
Beautiful. Remember that in normal pericarditis, the most common disease process and inflammatory condition, therefore you give NSAIDs to the patient. What happens to the patient with CKD, remember that prostaglandins are at the level of the post-renal arteriole. So if you give them NSAIDs, they're going to put the CKD worse, right? So how do you think you treat uremic pericarditis? If I tell you that the leading indication for hemodialysis is uremia, the only way to treat pericarditis on a patient that has uremia is by hemodialysis, regardless of their stage.
So you would use that for like a cat for that?
You're going to see the list.
So you would do like a temporary cat use for that?
That's the only way to treat it. Getting rid of the urea. Okay? And of course, you treat the same way as you treat an ATP3 guideline for hyperlipidemia, which you could come.
Doesn't the colchicine help with the urea and all those things?
Okay, colchicine. She's talking about colchicine. Well, colchicine, even though colchicine is not a non-steroidal anti-inflammatory mediator, actually acts at the level of the inflammatory cascade. So produces liver failure and renal failure, so you should use it. Now, once the patient has passed to prevent accumulation of urea, you could use colchicine instead of NSAID. In combination with allopurinol, believe it or not, this in CKD is a little different. Like, for example, normal patients have gout, you would use colchicine, steroids, or NSAIDs for acute disease, acute attacks, and for chronic allopurinol only because of the sampling inhibition. But for CKD patients, combination of those is beneficial.
That's after.
It's
the fact.
like here's your maintenance.
To prevent, yes. Okay? Anemia, you know that they lack erythropoietin, so basically giving them Epogen. In addition to that, I don't know if you have seen that patients with CKD not only receive Epogen, but they also receive cofactors from the bone marrow, which are iron. So you don't do it like spontaneously. You basically run an anemia panel, and sometimes they are iron deficient just due to the malnutrition, the GI tract that is in malabsorption and all that. So sometimes they lack cofactors such as vitamin B12 or folic acid or iron. So also investigate those cofactors to be able to replete them, because by itself, Epogen is not going to do the entire work, okay? They tend to have also a lot of angiopathy, so the blood vessels also tends to be, inflamed. So they have a lot of vasculitis, and urea can produce thrombocytopenias, and can produce basically dyscrasias, meaning that bleeding diatheses. Patients can bleed a lot. That's another indication for dialysis. So when the patients have severe thrombocytopenia or PT or PTT elevated due to uremia, you can correct that by dialysis. Now, this is a contradiction, but I don't know if you have heard that steroid use is detrimental for the kidney. Steroids can produce renal failure, right? But, for example, if what produced CKD would be a glomerulonephropathy that we studied at the beginning of this presentation, remember that I told you that many autoimmune conditions can produce glomerulonephropathies or glomerulonephritis? How can you stop that? Basically, the same way you treat those conditions, which could be methotrexate or cyclophosphamide or prednisone, has to be given, because otherwise there's no way to stop the underlying condition that produced the CKD. Do you understand? Unfortunately. Okay? As I told you, it can produce encephalopathies, and that includes aggression, irritability, can produce confusion, can produce, delirium, can produce up to the point of seizures and myoclonus. Okay? Restless leg syndrome, I already told you. So those symptoms that I'm going through one by one are symptoms of uremia. And whenever you have uremia, is an indication for hemodialysis. Now, patients with hyperparathyroidism having alterations of calcium and phosphate can precipitate increased hydrochloric acid, and therefore patients tend to have peptic-ulcer diseases. I talked to you about the gastroenteritis and all the diarrhea that the patients tend to have. Another factor of uremia, not necessarily the patient needs to have any of the symptoms that we have gone through, but just the uremic breath, smell of fetor is an indication of uremia, and that is an indication for dialysis as well. Even though you can see them all the time with uremic breath, and you don't take them to dialysis by guideline, it's an indication for dialysis. You can even have hiccups due to the irritation of the diaphragm. I told you already that they tend to have insulin resistance and therefore diabetes. I told you already that they tend to have alterations of sex steroids and therefore impotency, decreased libido, amenorrhea, or out-of-ovulatory cycles that can become pregnant. Anemia, I told you that. I told you about the accumulation of urea frost and therefore pruritus and excoriations and rash. And in addition to that, I told you about how detrimental is the uremia level with the platelets. Not only the hemodialysis itself can produce thrombocytopenia, but the urea accumulation can produce thrombocytopenia from bleeding. Okay? Nutrition. So let's start restricting these patients with protein, calcium, phosphorus, volume, etc. So as a general understanding, okay, the patients should not have more than 0.8 grams per kilo per day of protein. But if you don't want to measure the patient's weight and calculate 0.8, based on that, it has to be less than 2 grams of protein per day. Okay? That's the indication. Of course, you have to be more restrict if the patients have diabetes or not, due to being one of the major leading factors for proteinuria and CKD. All right? High carbohydrates, but not to the point to start breaking down into acids. We talked to you about phosphate binders, which is a vitamin D analog, which is calcitriol, one of the main treatments. Always try to restrict fluids. To how much? Really depends. If the patient is not in volume overload, you do 1 liter per day. If the patient is in volume overload, 0.5 per day. And that's almost nothing. Okay? Patient is in volume overload, 0.5, which is 500 mLs per day, your allowance. And if you're in volume overload, you have, if you're not in volume overload, if you're not in volume overload, 1 liter per day. If you're in volume overload, 0.5 per day. Okay? And sodium as well. Makes sense that if you're in volume overload, even though your allowance is 1.5 gram, or less than 2, depending on the book that you're reading, when you're in volume overload, you're going to limit the patient's sodium intake to at least 1 gram per day. Okay? Phosphate as well, less than 1 gram, because they naturally have hyperphosphatemia due to CKD. So try to be highly restricted with that. Now again, it's just to refresh. What are the uremic symptoms that we talked about? having anorexia, nausea, and vomiting, not related to another condition, because you have to be, or again, think about it. I went yesterday to a restaurant and had a food poisoning, and now I'm having vomiting and diarrhea. That's not related to uremia, right? So you have to exclude other etiologies, and there is none to be found, and the patient has vomiting and diarrhea, that is related to uremia. Having pericarditis, subpluralitis, having hyperkalemia or acidosis related to uremia, again, are signs and symptoms of uremia, and those are indications for dialysis. Let me open the, so I can finish. Remember that the prior PowerPoint had like 3 slides? It's repetition, but again, the classification for CKD is having a GFR of less than 60 for 3 months or more, and again, having more than 3, which is 30 milligrams, right? 3 grams per deciliter per day. We talked about the leading causes and how do you manage. Basically, we already talked about it. The leading 2 causes, if you have diabetes, you have to control the glucose level, because otherwise the progression of CKD will be expedited. The same as control blood pressure. And we already said that the first line treatment for hypertension is the inhibitors are going to be less contraindicated. All the risk factors, for example, smoking, that can produce vasculitis and can induce that. Treat the underlying conditions that precipitate glomerulonephritis. And again, we talked about dietary restriction of all the electrolytes and sodium and water. Calcium binders, we already talked about calcitriol. Erythropoietin replacement, because these patients tend to have monocytic pneumochromic anemia. We talked about how to treat metabolic acidosis. If you have end-stage renal disease, metabolic acidosis is treated by hemodialysis. And dialysis, of course, in end-stage renal disease, or when the patients have signs and symptoms of uremia. We already went through this classification. Now, we talked about this. Let me go over, we talked about all this already. Where is it? Wait, I jumped into the meeting. I know, where is it?
The last one.
You need to know this line. Indications for hemodialysis. First of all, you're in stage renal disease. If you're in end-stage renal disease and you're in volume overload, Lasix won't work. Bumex don't work. You need to do hemodialysis. And there's no bypass to this. Like for example, you can start treating hyperkalemia, meanwhile I program dialysis. But there's no other way to treat volume overload in a patient with end-stage renal disease. And the volume overload considerations are, the patient has pulmonary edema by a chest x-ray, that is a volume overload. The patient has anasarca by clinical findings, that's a volume overload, okay? Hyperkalemia, look at the potassium, more than 6.5, which all these patients can have it easily. That doesn't mean, again, that you're not going to start treatment with hyaxylate or insulin and dextrose. But, depending on the question, what would be the best treatment for hyperkalemia on an end-stage renal disease? Dialysis.
After you give like the whole insulin and dextrose, you can check the potassium in 1 hour.
You can recheck, but even if it's normal, this patient is going to bump
I just
up
want to make sure
again.
that it doesn't get higher because we don't hate that.
This patient has to be
But like
programmed.
within an hour, you
Right.
can check again.
Now, in addition to that, when you have a potassium more than 6.5, even if you're treating the patient, you must run a 12-week EKG. Because the potassium level itself can increase the refractory period of the cardiac cell and can induce cardiac arrhythmias.
Yeah, usually
Okay.
it has, and
What you see in clinical practice is that even if the patient has EKG changes or not, they give calcium gluconate just to decrease that refractory period. But in reality, the indications by guidelines, you must do an EKG first, and if there are signs and symptoms of hyperacute T, or prolonged PR, which is an end sign, you must give calcium gluconate. Metabolic acidosis. Remember that I told you that I was going to give you updates of the guideline? In the past, it used to be less than 7.1. Now it's less than 7.2. Don't tell me the slides are 7.1. Okay? Azotemia. Remember that even though azotemia is only numbers, BUN and creatinine, and uremia is symptom, uremic patients in end-stage renal disease needs to go to dialysis regardless of the value of BUN and creatinine. But when the patients are asymptomatic, a BUN greater than 80 should go to dialysis. Okay?
So,
Uremia always goes to
I know that was
anemia only.
Uremia, forget about the number. You have any signs and symptoms of uremia, you must go to hemodialysis if you are end-stage renal disease. Yeah. Even if you're moderate to severe, you have to start putting the catheter. Okay? Another indication for hemodialysis that we didn't mention, how are you going to control sodium? If you're mild to moderate and you're volume overload, and that's the reason why you have dilutional hyponatremia, I can give you diuretics and you can correct the sodium, right? Yes or no? But if you're in end-stage renal disease and I can dry you up with diuretics, how are you going to correct sodium levels? The only way to correct that is by doing hemodialysis. So extreme values, if you're hypernatremic more than 155 or hyponatremic less than 120, you have to go to hemodialysis. Do you understand?
dilutional hypertension.
In end-stage renal disease. How I'm going to take out that amount of fluid if I can use diuretics? Okay?
Do you have to,
If you are having any toxic drums that you're going to go over with me or whoever is your professor next semester, and the patient is in end-stage renal disease, how are you going to get rid of aspirin toxicity or Tylenol toxicity or any pantheon? Okay? You can take a break.